Hi, everyone. I'm Dr. Frank Edwards, and I work with Delphi as medical director of the Jones Hospital Emergency Department. I've been an emergency physician for 40 years, and for the last decade, I've also been involved in graduate medical education and have spent 5 of those years as a program director of an emergency medicine residency. This brief presentation on medical errors for Delphi physicians and advanced practice providers grew out of risk management lectures I developed for emergency medicine residents to help them avoid some of the cognitive pitfalls that busy healers can encounter in their daily lives. But the same concepts apply no matter where we practice. Okay, I should state that I have no conflicts to disclose, and by the end of this presentation, you'll be able to better discuss the nature and causes of error in a medical setting and discuss strategies to minimize error and bad outcomes, and be able to outline some good practice habits, and also be able to discuss some themes that arise from the peer review process that we do at Jones Emergency Department, and that is generalizable. Well, if we define an error as something happening that we did not intend with potentially painful consequences, this definitely qualifies here. But let's do a deep dive on what the causes of this particular error were. So you got a guy walking down the street. Well, there's ice on the street. That's certainly a causal factor on the sidewalk. There's, well, he's wearing tennis shoes. Not necessarily much traction there. That's a causal factor. It looks like there's an orange cone there. Somebody was trying to warn people of potential danger here, but did they salt the sidewalk? Doesn't look like it. But also the guy's carrying a cup of coffee, and maybe he was just distracted, taking a sip as he hit this stretch of sidewalk here, and bam, down he goes. So what all is going on here? It turns out that when you dissect any error, you can point to 3 different factors in the creation of that situation. Number 1 are personal factors. In the previous slide here, the guy was not wearing good shoes for icy sidewalks in the winter. He was potentially distracted, carrying a cup of coffee. And then there are process issues. Despite the fact that there was a warning cone by that slippery area there, it didn't appear to have been salted. But then there's a third factor, and that's providence, or the question of luck. It was a cold day. There was ice on the sidewalk. If that hadn't been the case, that error would not have occurred. So let's relate all of that to the practice of medicine. Personal factors, basically things that we can directly control, and they include our knowledge base, our procedural skills, our attention to detail, our compulsiveness, the quality of the handoffs that we give, and our documentation. In the emergency department, there's a ton of process or system issues going on at any given time. These are things that we can only control with the help of others. These include, not limited to, a chaotic environment, or how about medications coming in different concentrations? How about lab or x-ray reports that are erroneous? How about the difficulty in connecting with consultants or the lack of availability of consultants? Process issues contributing to error generation in the emergency department are legion, and it's understandable. These are wiring diagrams which display the difference between the way things occur in the emergency department with the chaotic things running everywhere, and in the ICU where um, the flow tends to be more controlled, shall we say. And the third factor, providence, are things that are completely beyond our control. And I think one of the biggest ones is the nature of a disease. Thoracic aortic dissections can present in all sorts of different ways. They can be the presentation can be subtle, and yet the potential for a bad outcome is great. So we can't control the nature of a disease or the way it's going to present. And then there are many distractions which we have no control over. You've got somebody yelling in the next cubicle. Your attention is drawn away. The high volume, it's wearing. And of course, the fact of the nature of our work in the emergency department, you're sharper at the beginning of a day than you are at the end of a day, especially if that's a 24-hour day. And that's unavoidable. It's the nature of the beast. You're probably all familiar with the Swiss cheese analogy in risk management discussions here, that for something bad to happen, it's usually when all the holes in the Swiss cheese line up. And indeed, that's the case. You got the guy about ready to get a lumbar compression fracture on the sidewalk there, wearing the wrong shoes, drinking a cup of coffee on an unsalted stretch of sidewalk, and there's ice. And when everything lines up, bad things can happen and the poop hits the fan. There was a time, many years ago, when there was a bad outcome in a healthcare setting that the search was on for the bad apple. The focus would be on the personal factors. How did this individual make a mistake, and so forth and so on. A more modern philosophy is that holes in the Swiss cheese lining up, that it's a process issue. By and large, personal factors may play a role. But if you've ever been involved in a root cause analysis in the past 10 years, the sources of a particular error or bad outcome are broken down into process-related issues, etc., and personal. But it's the human factor, the personal factor here that we're going to focus most on for the rest of this little talk, because it is the one thing that we have the most control over. And as long as we're human, things are going to go awry from time to time. It's interesting to just think of how a computer would evaluate a patient. Lord knows I wish we had tricorders. But the way a tricorder would evaluate a case would be based upon algorithms that draw from a huge database that look at every feature of a case, of past history, the demographic issues, and that would create a wonderful differential diagnosis and factor in all of them, and wouldn't miss the Luke esterase in the urine and so forth. That's not how we work. Our reflex way of thinking is heuristically, and that involves pattern recognitions based upon conscious and subconscious data, which is gathered by us to some extent haphazardly and integrated with our own past experiences and our knowledge base. That's how we come up with decisions. Works the majority of the time. We depend upon our right brain a lot. Because of heuristic thinking, we clinical people are susceptible to 7 types of cognitive error. There's availability error, representation, confirmation bias, attribution errors, affective errors, premature closure, and the mother of them all, anchoring. I know them well, I've committed them all. Then there's availability error, when we over or underestimate the likelihood of a particular diagnosis based upon recent experiences we've had. Classic example is you've recently missed a PE in a fairly young person, so your threshold for doing CTAs goes way down, and you start doing lots of CTAs, exposing people to radiation that don't need it, etc. Or on the other hand, you've gone through 6 weeks of seeing tons of benign chest pain cases that you've worked up to one extent or another, get a little cavalier, start to trust your judgment a little bit too much, your sixth sense, and then the real thing comes along and you potentially miss it. Okay, we'll start with something called representation error. Representation error arises when the clinician doesn't sufficiently factor into his or her workup the issue of disease prevalence. A classic example is when a clinician too quickly brushes off the possibility of an acute coronary syndrome in a healthy 65-year-old with atypical chest pain and a normal EKG. Another classic example is when the clinician orders a full court press workup for a thoracic aortic dissection in a healthy 16-year-old with sharp upper back pain. Now, this is not to say that the first patient definitely has an ACS or that the 16-year-old doesn't have a dissection, but age-related prevalence plays a role in how much we weigh signs and symptoms. Confirmation bias is when you cherry-pick data to support your favorite hypothesis. Patient brought back into the emergency department by the nurse who says, here, this guy, the drug seeker, is back. We've got a guy with opioid use disorder, he bounces back, he's got worsening low back pain, of course he wants something for that. Reports feeling feverish at home, but no fever in the ED, so how much do you weigh that? And last night he was diagnosed as drug seeking, so we kind of ignore that sense that the patient have of being feverish at home, and we miss the epidural abscess. Attribution error is when we stereotype, and you'll notice that there's a lot of overlap of these categories of error here. For example, the patient is comatose because he's got a load of alcohol on board. You can smell the alcohol in his breath, and we potentially miss the subdural. And then there's the combative, intoxicated guy who comes in after a motorcycle accident. We assume that the intoxication is the cause of his combativeness, and we don't notice in time that his PO2 is 80, and he actually has a pneumothorax on top of it. Affective error is when we avoid subjecting a patient to an unpleasant test or examination out of sympathy. And this is when we avoid doing the pelvic on the modest patient, or we hesitate to draw labs that we really probably ought to on a sick child, or hesitate to get a catheter, a urine specimen, and a 16-year-old female who really needs it, needs the urinalysis because we don't want to subject her to it. Premature closure is when we stop thinking. It's especially prevalent during shift change times. You come on duty, the outgoing doc gives you a case that's been pretty much all worked up. There's some things pending. Tells you what he or she thinks is going on, and you accept that without thinking independently. I had come to the habit the last half of my career of I would do it politely. The outgoing doc would present the case, and I wouldn't display overt suspicion, but I would just kind of listen quietly, and then after he or she had gone, I would go and see the patient and try and think on my own. I would carry a little bit of suspicion that perhaps what I was being told wasn't necessarily the truth. And electronic medical records can propagate incorrect diagnoses. You see what had happened when the patient was here yesterday, and you take that as what's really going on as opposed to independently thinking. It's a danger. And the last category we're going to look at here is probably where everything else, all the other types of errors point toward, and that's anchoring, where you cling to an initial impression even when there's conflicting data. An example is you've got severe epigastric pain in the 65-year-old who's got a history of recurrent alcoholic pancreatitis. But they've had no recent alcohol. The lipase comes back normal, and there's a slight ST depression, but you're sure the guy has pancreatitis. He tells you that's what it was like in the past here, so you stop thinking, and conflicting data, the fact he had recently been drinking and normal lipase, etc., slight ST changes there, you just stop thinking. So, we need strategies to avoid making these common human errors in the emergency department. I'm sure you're all, as we're going through this, have recognized, as I do, having made each one of these errors here. Fortunately, most of the time they don't lead to bad outcomes, but they can if the holes in the Swiss cheese line up. You may already do this, but let me share with you my favorite strategy for avoiding anchoring, and that is worst case scenario thinking, which basically means that you, based upon the patient's chief complaint, you imagine to yourself what's the worst several things that could be going on with this particular patient. Is that numbness in the left hand? Could that be a TIA? The 20-year-old who comes in with shortness of breath, could that be a pulmonary embolism or an acute coronary syndrome? It's a way of avoiding jumping on the simplest option first. Now that does not mean, please, that you have to work up that 30-year-old with the numbness in the left hand for a TIA, or that you have to work up for a PE or acute coronary syndrome, that 20-year-old with the shortness of breath. What it does is focus you on other aspects of the situation. For example, the shortness of breath case. If the oxygen saturation is normal and there's no risk factors, probably as far as you need to go, thinking of a PE. But it's the old saying is if you don't think of it, you're going to miss it. Sometimes. Okay, here are some special red flag situations. One is the patient who has syncopized before arriving in the emergency department, because a number of dreaded situations, including subarachnoid hemorrhages, pulmonary emboli, dissections, AAAs, ruptured ectopics, and the list goes on, often syncopize when the event began, but present to the emergency department, awake and alert. Anybody who syncopizes before they come in, be worried. And of course the pain out of proportion, you've got the terrible belly pain, but the soft abdominal examination. Compartment syndromes too, characterized by pain out of proportion. Anybody who's unable to bear weight on an extremity. Well, it looks like a sprained ankle, but they can't bear any weight on it at all. Maybe there's a fractured calcaneus. Also, a big deal is if there's any discrepancy between the physician and nursing notes, make it a habit, and never break it, to review the nursing notes before the patient leaves. I can't tell you the times when I've uncovered an interesting piece of information in the nursing notes that the patient did not give me that made a difference. Be very wary of making vague disposition plans. A vague disposition plan is follow up as needed. That doesn't protect the patient, doesn't protect you. Far better is for the disposition to be specific in both location and time. See Dr. Deppner in 2 days, or see your primary doctor in 3 days if not improved, or return to the emergency department tomorrow morning if your pain is not resolved. Things like that. Of course, making the arrangement for the patient to see Dr. Deppner the next day is probably the best of all. And when reviewing charts, something that is really concerning is when the patient was told to follow up with their primary care physician and they don't have a primary care physician. Be very wary of bounce backs. And I'm sure you are, but when a patient comes back for an unexpected revisit, the majority of times it's just a natural progression of disease, but sometimes there was something missed. This is a situation where you can get into the premature closure if you accept the previous provider's diagnosis. Always rethink it. And anybody who has left the emergency department and calls back later that night or the next morning, our nurses need to be instructed that you never not take that potentially seriously. And if there's any question, the patient should be invited to come back to the ED for further evaluation. Okay, a couple more thin ice situations. The malpractice case records are full of patients who were discharged with abnormal vital signs. And something bad was going on that just wasn't appreciated. The tachycardia, or the hypoxia, or the hypotension. And another, of course, is when abnormal lab findings were not appreciated. Well, the magnesium was 1.2. It had been ordered, but it wasn't noticed. The way to incorporate, I believe, an error reduction strategy into your everyday practice is to adopt a checklist mentality, just like they do in the airline industry. And here's a mnemonic: ADOPT, adopt. A, you ask yourself if you're anchoring. D, is your differential diagnosis inclusive enough? O, have I overlooked any discordant data? P, making a final pass over the vital signs and the nursing notes. And T, have you thought of the worst case scenarios? I know these are kind of redundant, but this will work. So as we near the end of this discussion, let's spend a moment reviewing some general good practice habits that are probably already second nature to you. Number one, make sure you introduce yourself and acknowledge everyone in the room. In pre-pandemic days, that might mean a round of handshakes, but it can at least be the making of eye contact with a nod and a smile for everyone there. And it took me a number of years to realize the fact that this was not a waste of time, but actually made the getting and giving of information more efficient and pleasant. Secondly, we're all familiar with the studies demonstrating that patients appreciate it when you sit to talk with them and that they sense you actually spent more time and gave them more attention. Third, make sure that you angle the level of your language to fit the patient. And it goes both ways, high and low diction. I was in an urgent care center not long ago, and the practitioner began explaining things to me at the 7th grade level. I suddenly didn't trust him anymore. He hadn't taken the moment it would have required to assess my level of understanding. Fourth, the value of letting your empathy show. I remember one of our EM residents who was so good at this. You'd look in the room and he'd be sitting there near the bedside smiling, and everyone else in the room smiling, like a love fest. He really put his personality out there, and patients loved him, and they listened to him, and they talked to him. And lastly, in a similar vein, don't leave stones of dissatisfaction unturned. An example, you walk into the room to discharge a patient, and the patient's sister doesn't have a happy look at all on her face. You start talking to the patient, and the sister looks away rigidly and folds her arms tight across her chest. Well, something is obviously going on. Uh, may or may not be important, but it could be very important. You need to know about it. You take a moment. If we sense dissatisfaction on the part of patient, friends, or family, it's prudent to ferret it out, to simply look and ask. Now, I actually kind of hate it when we emphasize the quote, risk reduction aspect, end quote, of these 5 habits. That's a negative way of looking at it, that we're trying to avoid angry patients and so forth. The real reason for exercising these habits is that it improves our ability to communicate with the patient. And communication is at the very heart of our art. It makes the work more fun as well, too. And while we're talking about habits, here are a couple of really good ones that pertain especially to the ED. If you already do these, bravo to you. First of all, any of you who've worked as an ED director is all too familiar with the complaint that goes, they stuck me in a room and ignored me for 3 hours, nobody told me what was going on, and so forth. I personally fell into the habit of checking in on people whenever I had the chance. For example, you've just finished seeing the new patient in bed 10, and you're on your way back to chart and order. The several seconds it takes to poke your head into room 5 and give Mrs. Jones and her family an update, just say hello, is not only greatly appreciated, but once in a while, you'll pick up a change in condition. And once you fall into this habit, it becomes easy and quick. And secondly, most of you probably do this already, but bedside handoffs for the really sick or unstable patient is just good care. In terms of things falling through the cracks, shift change time is by far the most dangerous. So every once in a while, a patient will present you with a golden opportunity to Monday morning quarterback the actions or lack of action by another physician or advanced practice provider. Most of us realize immediately the need to swim right away in this scenario and not take the bait. Because all you have to do is vaguely agree with the patient's concern about that provider, and more often than not, the patient will perceive this as full-throated condemnation of the other provider, which can lead to attorney visits and invariably makes its way back to Dr. X. So legitimate concerns about the actions of another provider, of course, should go through hospital QA channels where they could potentially do some good. Likewise, for a number of reasons, we should never sound judgmental regarding another provider in the medical record. And sometimes this can manifest itself in subtle ways, such as this, quote, the patient reports that he has been trying to see Dr. X for the past week without success, and the office told him today to just go to the ED. Well, the problem with a statement like that is it makes us sound unprofessional. We don't know the whole story. It has no place in the medical record. It doesn't help fix a possible problem. It can damage relationships and so forth. It just doesn't do any good. But we've all been tempted. But the simplest thing to remember is to never ventilate in the chart. Okay, folks, our last section here is going to be some observations from the peer review process. You may or may not know, but every month I review a selection of all of your charts. And yes, I know that it's Monday morning quarterbacking, which I'm sensitive to because I know what it's like trying to document thoroughly while also taking care of a lot of patients. It's not easy. So I have sympathy for that there, but I've seen some themes that I wanted to share with you here. Of course, our goal is to make everybody's practice and documentation as good as possible. One thing that I would love to see more on the charts is discussions of medical decision making. This is what I found, this is what I think's going on, and this is what we're going to do. Some people do a terrific job of that. Some people spend less time. But it's a very important thing, not only when reviewing charts, but it is your last chance to think about the case. So I implore you to spend time discussing your medical decision making, especially on the more complicated cases, including things like why you're going to admit the patient and why you're going to transfer the patient, etc. What did you think about? Why is it not this, etc. Also, it's important to mention previous visits, and actually this should probably go on the history of present illness, but I sometimes am surprised when I don't see this, when the patient's been in the ED several days before. Certainly most people do a wonderful job with it, but mention those previous visits. If you don't mention it, it's almost as if you weren't necessarily aware of it, which is, of course, not good. And again, abnormal vital signs, mentioning abnormal vital signs, highly important. Be wary of anchoring in elderly folks who present to the ED with their diagnosis on a silver platter. Okay, we're bringing in our 85-year-old father, and we're worried that he might, because his leg is tender, we're worried that he might have a DVT. In a busy ED, you look at a case like that and you say, okay, I just have to rule out the DVT and I'm done. But there may be lots of other things hiding in that elderly patient's history that are relevant here. So spend a little bit of time. Don't anchor on the obvious. And then finally, please, I think most of you do a terrific job, but the dragon, as we all know, can transcribe things in a way that leads to some embarrassing and nonsensical documentation sometimes. So give it a quick edit. Okay, we're essentially done. In summary, be aware of the types of errors that we're all prone to making, especially anchoring and premature closure. Control what you can, those personal factors, and learn from everyone's mistakes, including your own. I was going to mention that the one positive thing of having to do peer review is that you do discover issues and items that are worth sharing with other people, because that's one of the ways we learn. And one final thing that I would say is that be especially concerned about patients with potential TIAs. Our habit should be, at this point, is that if you suspect a TIA, go ahead and admit them for further workup. And that is it for now. There is going to be a brief quiz that you'll be required to take and send in to Delphi so that we can make sure everybody had a chance to go through this. I look forward to interacting with you all in the future, and please never hesitate to reach out to me via email or call for any questions or concerns. Thank you for your attention.